One of the biggest reasons that people stop their cholesterol medications or never even start them is fear of side effects. That fear is understandable, but a significant portion of what people believe about cholesterol medication side effects is either exaggerated, misattributed, or outright myth. In this video, we're going to give you honest, complete information about the real side effects that exist across every class of cholesterol medication and how to manage them if they happen to you. In our next video, we will tackle the 5 biggest myths circulating online with the clinical trial evidence that debunks each one. So let's start with what's real. First, let's start with statins. Statins are among the most studied medications in the history of medicine. Billions of patient years of data exist. Here is what the evidence actually shows. Muscle aches are real, but are frequently misunderstood. Muscle aching, stiffness, or weakness, called myalgia, is the most commonly reported side effect of statins. In real-world practice, roughly 5 to 10% of patients report it. However, here is something critically important that most patients are never told. It's called the nocebo effect, and it accounts for the majority of statin muscle symptoms. The nocebo effect is the opposite of the placebo effect. So when you expect a side effect, you are significantly more likely to experience it, even from a sugar pill. The landmark trial called SAMSON trial, published in the New England Journal of Medicine in 2020, tested this directly. Patients who previously stopped statins because they had muscle side effects were given bottles of statin pills and identical placebo pills in a blinded, randomized crossover design. What that means is neither the patient nor the doctor knew which was which at any given time. And what was the result? 90% of the muscle symptoms that patients experienced on the statin also occurred on the placebo. Only about 10% of muscle symptoms were causally attributable to the drug itself. This does not mean that the symptoms are not real. They are real and they're miserable, but they are largely driven by expectation and anxiety rather than pharmacology. And knowing this is liberating because it means most patients who stop statins due to muscle aches can successfully re-challenge with a structured approach. So if you experience muscle aches on a statin, tell your doctor. Switching to a different statin like rosuvastatin or pravastatin these are generally better tolerated by muscle-sensitive patients, or your doctor can reduce the dose, and that often resolves the problem entirely. Taking the medication every other day is also another option with certain statins. What about serious muscle damage or rhabdomyolysis? True rhabdomyolysis, where muscle breaks down and releases proteins that can damage the kidneys, is very rare. It's estimated at fewer than 1 in 10,000 patients per year. The risk increases significantly when statins are combined with certain medications, especially some antibiotics like clarithromycin, some antifungals like itraconazole, and the immunosuppressant cyclosporine. So always tell every prescriber that you see that you are on a statin. Warning signs are dark tea-colored urine and severe muscle weakness, not just pain. Seek care immediately if this occurs. What about statin-associated diabetes? It's real, but it's modest and it's outweighed. So statins modestly raise blood sugar and they increase the risk of developing type 2 diabetes by about 10% in people who are already at risk, meaning people who are overweight, have insulin resistance, or have prediabetes. In absolute terms, across large trials, this translates to roughly 1 extra diabetes diagnosis for every 1,000 patients treated per year. This is a legitimate concern and should not be dismissed. However, the cardiovascular benefit of statins in the same population far outweighs the risk. A 2010 analysis that was published in The Lancet calculated that for every 255 patients treated with statins for 4 years, 1 extra case of diabetes occurred. In one major statin trial, doctors had to treat about 20 people for about 5 years to prevent a heart attack, a stroke, or similar cardiovascular event. That's called the number needed to treat, or NNT. So the benefit to risk balance. All right, the concept of number needed to treat, NNT, versus number needed to harm, NNH is the most honest way to evaluate any medication. For high-risk patients on statins, the number needed to treat to prevent one major cardiovascular event over 5 years was about 20 patients. The number needed to harm for serious muscle damage was more than 10,000 patients. The number needed to harm for diabetes in high-risk individuals was about 250 patients in 4 years. So the math is quite clear. For high-risk patients, the benefit dramatically exceeds the harm. For lower risk patients, the calculation is more nuanced, which is exactly why the 2026 guidelines emphasize individualized risk assessment rather than just treating everybody the same. What about liver effects? Mild liver enzyme elevation is occasionally seen. It's usually temporary. Serious liver damage from statins is extremely rare. Routine liver monitoring is no longer recommended unless you have a pre-existing liver disease. Another drug that we should talk about is ezetimibe. It is exceptionally well tolerated. In large randomized trials, side effect rates were statistically identical to placebo. Occasional mild GI discomfort or loose stools are reported by a small percentage of patients, but they're generally mild and they often resolve. There are no muscle effects, no liver effects in most patients, and no diabetes risk. It does not cause the nocebo-driven muscle symptoms that statins sometimes do because it has no mechanism to affect muscle tissue. What about the PCSK9 inhibitors? So the PCSK9 inhibitors, alirocumab, evolocumab, and inclisiran do not affect muscle tissue and do not cause muscle aches. They do not raise blood sugar, and there is no risk for diabetes. The main side effects are the injection site reactions like redness, a little bit of itching or bruising at the injection site. That can occur in about 5 to 7% of patients. It's mild and it's temporary. Just rotating injection sites minimizes this. Some people can have mild flu-like symptoms, especially early in the treatment. And with inclisiran specifically, there is an association with urinary tract infections, joint aches, and upper respiratory symptoms in a small percentage of patients in clinical trials that were done. The main barrier to PCSK9 inhibitors is cost and also insurance, not safety. Manufacturer patient assistance programs can provide significant financial support, so always ask. Bempedoic acid. Some people can have gout flares because bempedoic acid raises uric acid, and it can trigger gout attacks, especially in those who have a history of gout. So tell your doctor if you have a history of gout. It can cause mild rise in creatinine. It's generally not significant. It can cause rare gallbladder inflammation as well. But important, no muscle aches because bempedoic acid's target enzyme is not active in muscle tissue. What about the bile acid sequestrants? Constipation. Constipation is common. It can be significant. Bloating, gas, nausea can also occur. And also these meds raise triglycerides and interact with many other medications if they're taken at the same time. So you have to space all other medications by at least an hour before or 4 hours after. Now, when do you call your doctor? Call your doctor immediately if you experience the following: unexplained severe muscle pain, weakness, or dark urine, because that could mean possible serious muscle damage. If your skin turns yellow or your eyes turn yellow or you have severe abdominal pain, if you have repeated gout attacks after starting bempedoic acid, or any side effect that is affecting the quality of your life. Options almost always exist. Never stop a medication on your own without talking to your doctor first. If you are having a side effect, there are almost always alternative medications that will work better for you. The real side effects of cholesterol medications are manageable. Muscle aches from statins, which is the most common concern, are predominantly driven by the nocebo effect that we just talked about, with only about 10% being really causally related to the drug based on the SAMSON trial. Serious muscle damage is extremely rare. The modest diabetes risk is real, but it's outweighed by the cardiovascular benefit in nearly every patient for whom statins are recommended. PCSK9 inhibitors are safe, they're well tolerated. Cost is the primary practical barrier rather than safety. In our next video, we will tackle something different: the 5 major myths about cholesterol medication that you've almost certainly encountered online, and what rigorous clinical trial evidence actually shows about each one of them.